Good morning, and thanks for the opportunity. Thank you very much for Vista for allowing me to be here to speak with you this morning. I'm Sean Hughes. I'm the director of the Cardiac MRI program at Vanderbilt. I also direct the Advanced Cardiac Imaging Fellowship at Vanderbilt. I'm a cardiologist by training, and the talk I'm going to give today is to discuss the underutilization of cardiac MRI and how Vista can resolve a critical gap in patient care, both in tertiary care hospitals and the community. Here are my disclosures. My institution is currently evaluating Vista for potential use. I may be speaking in the AI theater, but I don't even pretend to be an expert in artificial intelligence. First, what is Vista? Vista is software, intelligent software designed to automate and simplify MRI acquisition for improved quality, efficiency, and access to advanced imaging. And we'll talk more about Vista later in the talk, and I'll show you an entire scan done by Vista in the middle of this talk. But first, I'm going to start with a clinical case. So this is a patient, a 36-year-old female diagnosed with metastatic uterine cancer. And very shortly after her diagnosis, she experienced hours of severe chest discomfort and shortness of breath. She came to the emergency room and was extremely anxious, and while there had dynamic and impressive EKG changes. And lab work returned a very significant elevation of her troponin. And so the initial evaluation was an echocardiogram performed at the bedside that was poor quality, but was otherwise normal. So her LV function was normal. There were no regional wall motion abnormalities identified. Then she underwent cardiac catheterization, which was also normal, with no obstructive lesions. So we have a patient with clinical and biochemical evidence of myocardial injury, but a normal echocardiogram, albeit a difficult study, a normal coronary angiogram. What happened? Well, of course, this is MNOCA, or myocardial infarction with non-obstructive coronary arteries. This is not uncommon. What could be the cause of this condition? She does not have obstructive coronary disease. Well, here's a simplified differential diagnosis for MNOCA. This could have been an infarction anyways. Even though she doesn't have obstructive coronary disease, it's possible that she has non-obstructive disease and had plaque disruption. Possibly she had coronary embolism. She could have had coronary spasm, or this could have been a demand infarct in a sick patient in a type 2 non-ST myocardial infarction. This could be Takotsubo cardiomyopathy. She just experienced a very stressful event, being told that she had suspicion for metastatic malignancy. Takotsubo cardiomyopathy is also stress cardiomyopathy, or also known as broken heart syndrome. Or this could be myocarditis. Myocarditis due to a recent viral infection, or sarcoidosis, or other genetic or arrhythmic cardiomyopathy causes. Those are the three main diagnoses to consider in MNOCA. How can we further resolve this diagnosis? We need an imaging modality that characterizes myocardial tissue. You know where this is going. Okay? Cardiac MRI is the only imaging technique that offers comprehensive tissue characterization of the myocardium to discriminate ischemic, non-ischemic, and inflammatory myocardial injury. What might we expect it to show? Okay, so if this is Takotsubo cardiomyopathy, see here on the upper left, well, we might expect the CNAs to show apical dyskinesis, and we would see acute edema of the dyskinetic apical segments, but we would expect to find no late gadolinium enhancement, and over time, LV function would recover. If this were a myocardial infarction, we would expect to see a regional wall motion abnormality and a coronary distribution. We might see some edema due to acute injury. And we would expect to see subendocardial late gadolinium enhancement within the infarcted distribution. And finally, if this were myocarditis, we again would expect to see a regional wall motion abnormality, but in a non-coronary distribution. We might see edema in the area of injury, in the area of inflammation. And then we would expect to see subepicardial late gadolinium enhancement. that is the pattern of inflammatory injury, right? Infarcts cause subendocardial late gadolinium enhancement. Inflammation causes subepicardial LGE when there's damage. And in fact, early cardiac MR is critical in this patient. Okay, in fact, it really needs to be done while this patient is in the hospital because the diagnostic yield of cardiac MRI is high when performed within the first few days, but declines over time. You can see here, 80%, about 80% of cases of Minoka are solved by cardiac MR when performed in the first 3 or 4 days. However, that yield declines if performed later at 6 months, primarily due to inability to discriminate Takotsubo cardiomyopathy late in the disease process. So we've established that this patient must have a cardiac MRI and should have it early. How good are we at actually performing this? So I'm just going to use my home state of Tennessee as an example. So there are 114 acute care hospitals in the state of Tennessee. How many of them do you think have the ability to perform cardiac MR? Now the answer is at most 15. Now this is actually a significant improvement over just a few years ago. Okay, so you can see in my home city of Nashville, there are 8 hospitals that have the capability of performing cardiac MR. There are 3 programs, and I think capability is limited and a little bit sporadic at the other 5 hospitals. And then the rest of the state of Tennessee, there are only very few hospitals, and most of these are performing sporadic cardiac MR. But I can get in a car in Metro Nashville and drive 2.5 hours in most directions and not drive by a single hospital that even has the capability of performing cardiac MR. So another way to look at this is there are 100 acute care hospitals in Tennessee that cannot perform cardiac MR at all. Less than 2% of magnets in the United States are routinely used for cardiac MR. This technology's been around for over 20 years. What's happening here? And it's not just about Minoka. I just showed a clinical case to portray an example of the critical nature of this imaging technology. But cardiac MR is the gold standard for cardiac imaging across a widespread clinical application, as you know, to differentiate various cardiomyopathies, to evaluate chest pain, to do stress cardiac MR, et cetera, et cetera. So this patient happened to be scanned at my institution. Okay, now at Vanderbilt, we perform about 3,500 clinical cardiac MRIs yearly. We have 1 dedicated magnet to do so. But despite operating in 45-minute slots all day, Monday through Friday, we currently have a 4-month wait to perform an outpatient cardiac MR. And why is that? Well, that's because despite running as efficiently as we currently can, we're not performing enough cardiac MR at all at our other locations and in the community and elsewhere in Tennessee. And so the backup is at Vanderbilt. So I'm going to go back to our case in a moment. But next I want to talk about what is wrong here. Why over the last quarter century has cardiac MR not expanded? What are the 5 barriers, 5 main barriers to expansion of cardiac MRI, in my opinion, at least? So the first one is time. These exams can be inefficient. They can take 60 to 90 minutes, especially at a less experienced institution. They disrupt the general radiology schedule. We all know that. And a typical cardiac MR requires 300 mouse clicks by the technologist. It takes a lot of time. It's not easy. And frankly, probably a lot of MRI techs probably don't enjoy performing the exam for that reason. It requires talent. Okay? Expert cardiac MR technologists tend to be confined to larger cities and higher volume centers. There is only 1 expert cardiac MR technologist for every 20 magnets in the United States. Processing. Okay, generally requires specialized third-party cardiac MR software for analysis and post-processing of a typical exam. Most standard radiology packs are insufficient to process a quality cardiac MR. Interpretation. Okay, expert cardiac MR trained radiologists and cardiologists are very hard to find. Training and reading of the exam can be cumbersome. And then finally, and don't discount this as a major barrier, is inertia. Okay, and this is an actual quote from an unnamed a hospital administrator said to me when I asked about expanding cardiac MRI at their institution. He said, well, our magnet's busy and our patients are fine. Back to that quote later. Now I want to talk more about Vista. So Vista is software that automates and simplifies MRI acquisition at the direction of the technologist. Vista takes over the exam from the console and completes a pre-specified protocol on its own, including setup, tomographs, CNAs, flow, and scar imaging. Further, Vista recognizes artifacts on its own and alerts the technologist, and then corrects and repeats those images, and also can determine the ideal inversion time. If you perform cardiac MRI, you know that can be difficult for the technologist sometimes. Software can determine the ideal inversion time to null myocardium and assist the technologist during imaging. Okay, so this product was developed by neural networks that, again, I do not understand, but can automate the tasks of an expert technologist with speed, precision, and consistency. And at the end of the exam, even performs inline analysis before the patient leaves the scanner. This is the only third-party software that can control the MRI machine for image acquisition and reconstruction. Okay, so enough talk. I want to show you this product at work. I'm going to show you an entire exam, much of it in fast motion, so we can do this within the confines of this talk. Okay, so that's playing. Okay, so you see the technologist. Her console's on the right, Vista's on the left. Now we're going to show you the Vista console itself. Now Vista on its own is setting up the exam. It's performing the localized. You see the short axis stack is lined up. The long axis CNAs are lined up. The 4 chambers lined up. The aortic valve CNAs are ready to go. There's 4 chamber. Okay, the scan's completely localized. That could have taken about 10 minutes of total time for the technologist in a standard exam. It just took seconds with Vista. Okay, the scan's already set up. She's clicking a pre-specified protocol. This is a non-contrasted cardiac MR for function assessment. So Vista is now performing the short axis CNAs in a stack. Halfway through the short axis CNAs, you can see artifact is detected. Okay, so you've got artifact here at that mid slice. The technologist was informed of the artifact. The technologist is currently telling the patient, please be careful and hold your breath. Vista will come back to that slice later in the exam to correct it. The exam moves on. The short axis CNA stack is done. Now Vista is performing the long axis CNAs, 4 chamber. It's already lined up the 3 chamber. That's done. Now this is sped up for purposes to get through this talk, but it's doing all the inflow velocity flow mapping. It's color coded. There's 3-plane velocity flow mapping of the aortic valve. All the while, Vista is telling the patient to hold their breath appropriately, so the technologist doesn't have to do that. The technologist can just watch and coordinate the exam as necessary. Now, inline analysis is being performed, but Vista remembers, of course, there was artifact on that one short axis slice that we need to go back and correct. And so the technologist is triggered for that to happen, and now Vista is going back to correct any of the images that had some artifact in them. That's done here at the end of the exam. That is now completed. That short axis slice that needed to be better is done. The technologist is now reviewing the images. The technologist is reviewing the inline analysis. You've got complete volumetrics of left and right ventricle here in the bottom left of the screen. There's your complete volumetric analysis. It's done. The technologist is walking into the magnet. That's completely done before the patient gets out of the magnet. Okay. The entire exam and analysis of volumetric function, left and right ventricle, is complete. Okay, so does this actually work in the real world? Yes, it does. Raymond Kwong's group at the Brigham it's published a 2-year analysis, or 2-year follow-up for an experience in Jack. 26% faster scans with improved image quality and consistency from all technologists, a 50% reduction in scan time variability, enabling shorter scheduling blocks, 1-day access to cardiac MR reduced from a 28-day backlog. Okay, so you can see here on this chart at the Brigham, wait time was 20 days prior to utilizing Vista, dropped to 0 days after utilizing Vista. They were able to add double their scan slots, or just by a third, 50% more scan slots, enabling 900 additional scans with existing resources. And this improvement was shown across all different types of sequences. So whether it's cine imaging, scar imaging, or perfusion imaging, quality improved. The scan time and consistency improved across the spectrum of technologist experience. That's key. So whether it was a less experienced technologist or a very experienced technologist, scan time was reduced across the board. And the scan time was reduced across all clinical indications. So whether a stress cardiac MR or evaluation of cardiomyopathy, scan time was reduced. Now here's an example of one patient scanned twice. So this same patient was scanned on day 1. The exam took 56 minutes and was fraught with artifacts, so almost a non-diagnostic exam. The same patient scanned the next day using assisted technology with Vista. Scan time reduced to 33 minutes, high quality images, and improved accuracy and quality. Same patient. So I propose that Vista Cardiac reduces the primary barriers to producing quality and efficient cardiac MR. It reduces scan time, improves image quality across the spectrum of technologist experience. It eases processing and interpretation via automated and assisted image analysis. And this, I think, is the key. This last point that I want to make is that Vista reduces the activation energy to start new cardiac MR programs. Starting a cardiac MR program can be daunting, very difficult. How are you going to find the talent? How are you going to find the time? Who's going to read it? Who's going to do the post-processing? Vista makes that easier, and maybe this can be a key to reducing the activation energy for community hospitals or even tertiary care hospitals that are not yet performing cardiac MR to finally start. Okay, so we're getting towards the end of the talk, so we'll go back to our case. I'll ask you to think about the case I presented and just guess. I'm going to tell you that the answer for this patient with Minoka is either an infarction or Takotsubo. Okay, so think to yourself, what do you think happened to this patient? Again, recently informed of the diagnosis of metastatic uterine cancer, hours of chest pain and shortness of breath, extreme anxiety and dynamic EKG changes, troponin elevation, Minoka. Which one do you think it is? Okay, so here's the cardiac MR performed at Vanderbilt. On the left, you see the short axis cine stack, and I'll point out to you there is a subtle area of regional hypokinesis at the mid-anterior wall, even though overall LV function is preserved. And on the right, in scar imaging, you'll see subendocardial late gadolinium enhancement in a diagonal branch distribution, indicating myocardial infarction. So this is an infarction in a diagonal branch distribution that's possibly embolic. However, that's not all. This patient also has apical hypokinesis. Maybe you can appreciate here at the arrow, the apex is not contracting at all. You see this in the forechamber also. However, on scar imaging, there is no late gadolinium enhancement at the apex. This is Takotsubo cardiomyopathy. So I may have fooled you, but this patient actually had both. The patient was found to have both an infarct, unexpected, and findings of Takotsubo cardiomyopathy. Now, I'm not sure I'd ever seen that before, and how might you explain it? I'm not going to pretend like I know the answer here, but I can offer you an hypothesis. If this patient has a metastatic malignancy and has thrombophilia likely associated with that. And so she may have had an embolic infarct down a diagonal branch without obstructive coronary disease, causing pain, and then the stress of an infarct also causing Takotsubo cardiomyopathy in the emergency room. Or it could have been the reverse. She could have experienced Takotsubo because of curing of this diagnosis and stress, had apical dyskinesis and formed an apical thrombus in the setting of thrombophilia, which then embolized down a diagonal branch. We'll never know. okay, but it was quite a fascinating case and an interesting case to show cardiac MR making two diagnoses at once. I'm going to leave you with one point. Is that for those of you that either have already started a cardiac MR program or are thinking about starting one, cardiac MR needs a cheerleader. So the most useful advice I received from my mentor, Deepan Shah, is that show your colleagues the images. Okay, if you're performing cardiac MR, you can't just hang a sign up and say, we're doing this today. These images are fascinating. Send the images to your colleagues, and they'll be fascinated and kind of blown away by the pictures. And even the cardiologists want to understand how they have been able to perform cardiac MR or treat patients without performing cardiac MR in the past. So the next time you're confronted with this quote, "But the magnet's busy and our patients are fine," maybe with the help of a product like Vista, you might respond, "The magnet can be busier and our patients deserve better." Thank you very much. Please visit Vista at booth 5352, and I appreciate your time.